you and concept. I will also show you that in different levels of calcium, you can actually differentiate dense calcium from not so dense calcium, which is difficult to otherwise differentiate by just the naked eye. The difference is very simple, that cadmium telluride comes as a semiconductor, and it's a crystal that gets incorporated. And X-rays, when they fall on cadmium crystals, they convert it to an electrical impulse, which is direct. And that is what is a photon counting. So each photon of cadmium will actually generate one image, so that's the pixel. In a routine CT, you otherwise get into a scintillator. The X-rays fall on a scintillator. The scintillator then converts it into an electrical signal, and there is a noise. And because of the noise, the clarity is not there. You can see the waveforms are crystal clear on the panel to your right, and the routine CT is to your left. These are the images that we could generate, and virtually it looks like coronary angiography is just a process left before an intervention rather than a diagnostic test in any level of calcium. Let's start with a simple case. 67-year-old, effort angina, 2 episodes of loss of consciousness. And this is a CT showing a high-grade RCA over a long segment dominant RCA. What is important is that as you take, these are called MIPS, and these MIPS can be rotated, and as you rotate them, you can not only visualize the concept of the lumen and the wall, but you can understand what view is going to be best to cross these CTO segments and how the wire is going to interplay with calcium as it goes across. And as we advance, I'll take you a little deeper into this. So having said that, this is a VRT which is there, and this VRT can be rotated in any three-dimensional axis to get the right concept, to know that the RCA here, you can see that if you look at the right coronary angiography, which is your conventional angiography on one end, and the CT, it is no rocket science to know that the information that you got from the CT is far in excess, far superior than the angiography, because the angiography beyond the CTO segment is blind. The CT is not. So I think that's the important. It tells you not just the path. The information is huge. It tells you density of the plaque. It tells you whether the Hume's value would suggest a soft wire crossing or a moderate intensity wire penetration. It gives you the length of the CTO more precisely. And it gives you a fair idea of collaterals as well, to a large extent. We can tell different branches downstream, and I think we can plan. Not only that, if you take the cross-section at the aortic end, you can, before you even start the case, you know what guiding catheter is best going to suit that case. That's important. So here we started off this case routinely using a run-through wire and a microcatheter. We escalated it to a fielder XTA, and then to an UB3, and subsequently a Gaia third to make progress. And the reason for escalation is, if we went on with a wire, and for a minute or two, if we find that we're not advancing the wire, then we make a rapid change and escalate to get ahead. And as we advanced into the case, we saw that we reached somewhere close to the distal cap, but we saw that the wire was a little subintimal. Now here is where we go back to the CT and we realize our relationship of the lumen to the calcium that was in the path. And when we change that, We reorganized the wire, we redirected the wire on the wrong side of the calcium, on the right side of the calcium this time, and it took us to the distal cap penetration. Now we have a microcatheter which is struggling to go across. So we have a wire, a Gaia third next, gone through, and now a microcatheter is struggling to go ahead. This is not an RCA that you can deeply engage, because once you deeply engage, because of the proximal osteal plaque, it's difficult to deeply engage a guide catheter. So under the circumstances are, of course, and this is not the topic of concentrate, but we used an excimer laser. We used around 5,000 pulses to get across this, and we achieved crossability in this lesion. And then from then on, the microcatheter passes, you get your normal standard wire in, you get an IVUS catheter in, and it becomes a regulation angioplasty. We do a cut based on IVUS sizing, and once we do that, stents, making sure that it's right at the ostium using diagnostic catheters to identify the ostium while we are doing this, and then this is our final result. So this case actually gave us the path of the wire, and it also told us that the density, it also showed us the density in the mid-segment was high with a little bit of calcium, which was really the reason why the microcatheter didn't advance over the wire. This is a 57-year-old gentleman, progressive angina for last 6 weeks, over angina of 1 year, and now it has progressed in the last 6 weeks. Besides his circumflex OM, which was tight, which is probably the reason for his recent progression, this was the LAD lesion that we saw. Right after a right major diagonal, you can see a long segment of occlusion with varied intensities of tissue that you can see in terms of the fluoroscopy in the CT signals, ending up with a calcified distal plaque in that sense. And when you look at these seriously, this is the angiography image to the left. It's a long segment CTO with collaterals from the right, and you can see that there is exactly the same definition, that large diagonal branch. You can see a tapered tip. You can see the part of that you see nothing. You see no contrast. Then you see calcium. Now what you can do with this is, and we also know that the landing is going to be somewhere before the bifurcation, that you're going to be okay. So if you get your wire in any one of the branches, you're going to be okay to start opening them up. Now having get this information is not enough. Then we go ahead with the same CT, and we can take points and we can look at the Hound's value at their various levels. And you can see that as you go proximal to distal, it's 168, 98, 124, 114, and then more than 350. What is it telling you? Hound's value of less than 60 or 50 indicate lipid plaque, soft plaque, lipid or thrombus. When you go to 50 to 130 or 125, you're looking at fibrous, and as it goes to about closer to 120, the fibrous cap is a little more intense. At 130, it's an indication of calcium, even if you don't see it fluoroscopically. And so from 130, when you get on, you can get on to 1,000, 1,200 intensity Hound's value. And as you go up, we realize that when you have Hound's values of more than 600, it's very likely that you're going to need an atherectomy for these kind of patients. So we knew that approaching the distal cap will require a high penetrative wire given the circumstances. Now here is where we take the CT. We take the CT VRTs, as I showed you, and we import them onto our cath lab fluoroscopy. And when you import them, you see the final image, you can see a CT to your right, and your fluoroscopy is on that left. And the blue line is the identification of the central lumen in the CTO segment or the LAD. It also reads the other branches, and which we can ignore. But you can see that this is your LED corresponding to your LED in there. Every time you move your C-arm, this image will move correspondingly. So you could actually have this relationship with you in any angulation that you choose while you're doing the procedure. You cannot just have this, you may even want to at some point have an overlap of your CT image on your fluoroscopy. So you can have a reduced opacity image of your CT BRT on your fluoroscopy so that it becomes your navigation path. And so we chose a UB3, we could not advance beyond this point. We had a Turnpike LP as a microcatheter in this particular case. Actually, no, it was a Corsair Pro XS. And we changed to a Gaia Third next, and we made some progress. Cautioning that we can see, I mean, you can't see it on this video, but there's an island of calcium over here on the fluoroscopy which you can identify. Now the problem is that I have choices of where my wire goes. I mean, you just point and you push. You don't drill with the Gaias because you don't want to increase that space. Now when we look at this, we see that the wire looks like a little subintimal, a little away from the calcium. Now what is interesting, and I want to take you back, is that in the CT, when you look at the CT, you can take cross sections of your CT at various levels, and you can predetermine the relationship of your lumen to the calcium. So if you know that you're in an RAO cranial view, you can actually take your CT there, do a cross section, and you know whether your lumen is south, north, posterior, anterior of that calcium plane. This helps you navigate the wire truly to the true lumen in most times. So here we knew that we are subintimal, and then let us look at how we changed this navigation. So here is the image of where a wire is, and I can tell, I'm not sure if you can see that on that image, but it's a little subintimal, and you don't want to advance too much because you're going to extend it and then compromise the true lumen. So here I can see my wire pointing down, and my true lumen is somewhere up there. So I need to just pull back, upswing the wire, and then make an advance, which I did. And with that, we are then now in the true lumen that we can tell from the retrograde. Once the wire is in the true lumen, we need to advance the microcatheter. And of course, that again was a challenge. So in this case, we knew that that was going to be a challenge. You go back to your Hound's value of around 400 or 470, it becomes difficult for the microcatheter to advance sometimes. I mean, you can take smaller balloons, you can do many things. Our experience and my experience tells me that in this level of calcium, if I can truly modify this lesion, not just achieve crossability, but if I can modify the plaque with a single device, like an excimer laser, then I don't need other tools to do much to the calcium. And that is exactly what we did. We did an excimer laser with saline, around 3,500 runs, and then 1,800 pulses with, 3,500 pulses on 5 runs at 80-80, and 3 runs with contrast. Now contrast, because it's a CTO segment, sometimes you don't get enough volume of contrast in front of the catheter, so it may not be as effective. But in this case, the LCA still did not cross this one point. But what it managed to do is it managed to make that, modify that lesion enough to enable my microcatheter now to slide into the distality. You can see my microcatheter just walks through, which it wasn't before. Now, once we do that, we look at our iris images, and as I mentioned to you, whenever I have done LCA with contrast, my iris images have shown cracks in the deeper calcium. And This initially we thought was just something that we are looking and visualizing and kind of over-reading. But now when I analyze our work over the last 4 years, this is almost a consistent pattern that it emerges, in my opinion, as a single vital tool which can kind of alter the plaque enough. And from here, it's you go to, you lace, you cut, and then 2 stents later, you can then finish the case with this kind of a result. Yeah. Coming to our last case is this 67-year-old with recent ACS, preserved LV function, and we got a CT coronary done, and this is his right coronary artery. You can see very close to the ostium. You can hardly see a little of that proximal origin of the RCA. He also had a calcified LAD 90% with a left main stenosis, which was very, very critical. You can see both those lesions in these VRTs, but here that VRT is basically to concentrate on the right corner, on the RCA, and you can see this RCA is a fairly short segment. But when we analyze this CT a little more, you can see that the segment actually, go back. The segment, the true lumen, actually is between plates of calcium and then starts over here. This is where the distal cap is, approximately. So my CT tells me that I have to go between those plates of calcium to get to the true lumen. And that's a very small area though. It also tells me the relationship to that proximal calcium over here. So when I start that case, what happens is, how do we take these images and take it forward? So when we use this SYN CTO guidance, it enables our segmentation of our coronary CTO to be incorporated into the CNA fluoroscopy system. And then we can color code our coronary to avoid any foreshortenings, and we can actually identify the RCA from the circumflex and this and that. So we see this kind of an image which we saw from the CT on your fluoroscopy, and now you can actually allow this, you can take by choosing your LAD or unchoosing it, you can decide to show just one artery or you can show all the 3 arteries. You can see relationships. You can choose what you want to see on the fluoroscopy. You don't have to clutter it with noise. Not only that, you can then use your map to go ahead, and you'll see a yellow marker coming in, and you can map the center of the lumen in the artery of your choice. Like most times I would take all the 3 arteries and do that. And the reason to do that is that we have a lumen, and the CT allows us to be in the center of the lumen at every cross point. So you take cross points from the proximal to the distal, you can see this marker coming over here. The job of this marker is to identify cross sections, which we are doing now, and we can go and you will see a small cross box over here which shows you the transverse section at every level, and then you trace your true lumen all the way from the top, whether it's occluded or not, you just trace it all the way downstream, and that becomes your central line. Can you see this cross section now? And you can see your calcium, and the bloom allows you not to see the true lumen, but you can adjust that bloom based on, you can cut it or store it, and then you can see the lumen here, and you are mapping the true lumen. Can you see you're mapping the true lumen on this longitudinal MIP, and you can see the relationship of those plates, and the lumen is between the 2 calcium plates, as I told you, that you already know the path. Now this exercise brings you to an image like this, on which you visualize, and now you can see a line which is drawn, which becomes your roadmap to take this further. Of course, there are steps which you will follow to kind of get them in. So having done that, we started off our case with a run-through wire, and this is just to engage into the right coronary artery and get a microcatheter there. We went to a UB3, and these are the images that you see. And when you look at this image, you can see that my run-through wire is way away from where I want it to be. The directions, whether you look in this view, which is your LAO view, or you look at it in the RAO view, in the RAO view, I thought I was doing okay. But when I look and superimpose these images, I'm far from okay. So where do I need to be? I need to be downstream here, or I need to go between the calcium tracks over here. This is my path. Basically, that allowed me to take a wire into that path. Now, with that path, you then know now you're in the right direction because you're heading towards the distal cap here. You can see that the white lines don't match your coronary lines. There's a little discrepancy. So why is that discrepancy? Why is it not a perfect match? Because we realized that when we do CTO angioplasties, the patient has his arms next to the sides. When we do a CT coronary, the arms are up. And when the arms are up, it takes away the bony landmarks. The sternum moves, the ribs become more horizontal. And because of that, you cannot have a perfect overlay. The whole system changes. So we have changed this, and now we get our CTs for CTO with arms like how it would be in the cath lab. And now the overlays are almost perfect. I think the next iteration will not just show the central line, it will also show the true lumen, which is there, besides making our job a little easier. So we then move to the distal lumen, and from here on, you're on your own, because now you're trying to penetrate the distal cap, and the CT doesn't tell you how to penetrate the distal cap really. At least it doesn't tell us so far. There will be a time when we'll be able to do CTs in the cath lab at this point and be able to tell us where we're heading. But here we were subintimal again, and when we were subintimal, now we have three choices. We could do a parallel wire. We could do a parallel wire, and that's a good choice. We could do a retrograde approach with but the left side is critical, so that's a little challenge. Or we could go subintimal and then do a re-entry based on IVUS, come back into the true lumen and complete the case. So we started off with the most comfortable position here is a parallel wire. So we took a stiffer wire. We had a UB3, we took an Agaya third next as a second wire. And you can see as we go from the left image to the right image, you will see that this is at the proximal cap. We've gone into the true lumen, and you can see the wire advancing into the true lumen, which is confirmed by your retrograde pictures. So basically, the parallel wire was a good choice in this situation. And then you complete the case like a usual angioplasty, and I don't want to bore you with those little things. In conclusion, it's intuitive, it's exacting, it's insightful. The CT acquisition with hands by the side is what we have now decided to do to make it a little better. CT is CT guiding not just for CTO, but for most complex PCI. I think it is the thing of the future, and I believe that this will tell me more even before I go to the cath lab in terms of choice of devices that I may need. It is not just a roadmap, it's a procedural guidance tool, and I think it's far more expansive than being just a roadmap. And I feel that if we use it correctly, it could be a game changer. Thank you.